Good evening. Thank you for joining us. I have the great pleasure of being here with Dr. Randy Smart, and this is another episode of The Doctor Is In. And thank you for spending some time with us. And
my pleasure. My pleasure.
Now, this is going to be the second one on COVID.
Correct.
And this is the first one. If was more of your personal experience on going through personally. Now, this one is kind of updated, maybe treatment stuff, questions you're getting, and questions supervisors are getting, that type of stuff.
Sure.
So, in fact, let's start off with those. I know this is one where these were questions from Calaveras County Supervisor. And after being infected with COVID-19, is it recommended that you still get a vaccine shot?
The short answer is yes.
Okay.
But there's a little more to that. We believe that 99% of people that get infected with COVID develop a natural immunity. What we're unsure of is how long that natural immunity lasts.
Right.
Some say 6 months. Some think maybe longer. It gets pretty complicated, John, in terms of how you measure immunity. It's not just measuring antibodies, it's more complex than that.
I guess the question on that is some of the stuff that's come out in the last few weeks with some of the variants. So you think this may be something to where, use Moderna for example, is they come out with a booster every couple years it's kind of like the catch-all with a lot of the different to where if you take if you get this booster every couple years, I'm just pulling out of the air, but there may be something to where you have the initial vaccine and then every so often you need a booster, type of thing, or maybe it's like the annual flu shot type
possible.
Of thing. Okay.
Yeah, very possible. Not far-fetched at all. In fact, very possible. But back to the supervisor's question. We do recommend you get the 2-shot series after you've been infected. But a little bit of warning. We've vaccinated a number of the healthcare force in Calaveras County over the last month, and we can tell you that those that have had COVID and get the vaccination is much more symptomatic. So the kind of symptoms you have after the vaccination, if you've had COVID, you could multiply.
They're more pronounced.
Yes, okay. More pronounced. And then when you get the booster, I actually sent 4 people home today. Actually, 3 of them were already home. I sent the 4th one home because they have fever, they have joint pain, they have headaches, and and these are not lazy people.
Right.
These are workers. And man, they're in bed. And some of them are relatively young, 30, 40, and then some of 50, 60. But I guess my point is we recommend it, but we know it's going to be a rough couple days. And we don't know where that's going. Like you say, do you need a booster every 2 years? Not sure. Do we need to start all over? Possible. Possible. These variants are very, very easy for the virus to produce, if you will. And so viral mutations are just, they're basically mistakes that work. It's like putting building blocks together and you did it the wrong way, but it worked even better. So that then becomes transmitted and so what I worry about is that starting all over scenario where we've all been vaccinated or those that are willing and we all feel protected, either natural immunity or vaccinated immunity, and then something comes out of some country and we say, uh-oh, we need to start all over. Mm-hmm. And I don't think that's far-fetched, John. I'm not trying to be a pessimist.
Right.
I'm a science guy. That's what I
So
do.
people are looking for the light at the end of the tunnel, and it may just be a long tunnel that we just need to keep going through.
Need to be cautious.
Yeah.
Need to be really cautious.
Yeah.
Right. One of the things I was hoping to talk about tonight was what we call long COVID. I think some people call it long haulers. Interesting story about that. The lady was somebody who was tweeting. I think she was tweeting, but her husband was a long hauler, and she had a long hauler hat on, and so they called it long haulers. And funny how things get named, right?
Mm-hmm.
But it's called long COVID. The medical community has this big long name, post-acute COVID-19 syndrome. But it is a very real thing, something I'm personally concerned about, not about me, but about our community and about the humans in our community. And I wanted to spend a little bit of time on that. Again, if you go back a year and replay, we, myself included, said, this is really no different than the flu.
Right.
It is. It's different than the flu. And a couple simple facts. 2/3 of the patients that get symptomatic COVID still have symptoms 60 days later.
So the chronic ones are, you would say, what? Headache? What are the, doesn't, I mean, just what
Sure.
are you seeing? What are you seeing as far as chronic stuff?
The symptoms are more seen in women, or this post syndrome is more common in women, and we can get to why that is in a minute. But fatigue is a big part of it.
Okay.
Headaches are a big part of it. In fact, 30%, 60 days later, feel no better than the day they got sick.
Oh, wow. So it's debilitating almost for some people.
Yes,
Okay.
exactly. And I think we mentioned this before, 11% of people that get COVID have not gone back to work. I mean, big numbers. So you take a country like the U.S., 300 million or whatever, what they're reporting, I think, as of this morning, was 26 million recognized COVID cases. What's a third of that? 8 million? 8 million and some change. So there's 8 million people out there that are not getting better. And that's a lot of people.
Wow.
That's a bunch of people. And we're not hiding that. I don't think anybody's hiding that. It just, we haven't got there yet. And so what is happening is we're talking about COVID, the acute COVID, like
Yes.
ICU hospitalization, we're talking about the death rate, and these are important things to talk about. We're talking about vaccinations, we're talking about the economy, but kind of looming in the corner of the room are 8 million people that are debilitated and need help.
Has the medical community started looking at specific treatments for that? I mean, you try to look at some way to try to, symptom. I mean, have they started looking at things for that?
Well, the way I would describe medical activity around that right now is they're trying to learn more about it, so they can figure out what is this,
Right.
and how do we treat it. Now, something very interesting to me is, and I don't know if you've heard about this or not, there's a disease called chronic fatigue syndrome.
Mm-hmm.
And chronic fatigue syndrome is something I heard about in 1981, 40 years ago. And
People kind of made fun of it. Some of the victims of it.
You're a wimp.
Yeah.
It's all in your head. You need to go see a shrink. Well, we've learned over those 40 years that is not true.
Yeah.
It's a real disorder. It is a little bit hard to quantitate. I mean, your blood tests are normal, your x-rays are normal, all the conventional stuff we know turns out normal. But there are definitely abnormalities we know about, but they're done in research labs, not in clinics. Like there's something called natural killer cells. And these chronic fatigue syndrome patients have many, many more of those than the others. And so it's becoming much, much more of a recognized objective disease.
In that family of the immuno disease, I mean...
Yes, immune
like
mediated.
a lupus, like a...
Yes,
yeah, like
yes, autoantibodies.
Okay.
Autoantibodies. So chronic fatigue syndrome and post-COVID are starting to look very, very similar.
Okay.
Now they're not the same, but they're cousins. I mean, they're close. And what we know is that if, let's say, you had post-COVID, 60, 90 days out, months out, your blood tests look normal, your x-rays look normal, you're just sitting there saying, Doc, I really don't feel well. We go, well, not a lot we can do. And so the researchers are taking some of this chronic fatigue syndrome research and trying to apply it to the post-COVID problem. And there are some interesting things that are coming out of that. But we are going to be really, really busy taking care of millions of people that don't feel well and maybe can't work. And we're not even talking about that yet. We're still talking about vaccinations and
not only in the medical community, the economic impact of, the economic impact of that, everything. Huh?
Exactly. Yeah, exactly. It is right around the corner.
Historically, is there anything history can teach us about the 1918? The years after the chronic, the epidemic of 100 years ago. That was a painful process for the world to get back to normal after that. It wasn't an overnight thing at all.
No, years. And medically, I can't speak for economics. I don't know anything about. I can barely balance my checkbook. But medically, there are lots of models for this. And we were talking about this morning with my medical group. Is rheumatoid arthritis is one of these diseases where your immune system starts attacking itself. Lupus is one of those diseases. But then there's infectious diseases like Lyme disease would be one. Epstein-Barr virus that causes mononucleosis is one. Herpes is one. And so what we know about chronic fatigue syndrome, I think most of us acknowledge that it's triggered by an infection. So you get some infection, whether it be mono or something, that triggers this, and then your immune system just won't settle down. It just won't do it. And so you become a chronic patient for years and years, to the extent where you can be in a wheelchair or be in bed. And so when we go back and look at those models like 1918, and we look at this is something that we've seen before, but probably not quite at this magnitude, and we don't know a lot about what to do with it.
Right.
Or really how to diagnose it. Me and my colleagues, we like testing. Mm-hmm. We like people to come in and we say, okay, your test is positive. That's a good day because I know what's wrong with you. I know what to do about it.
We know what it is.
There is no test for chronic fatigue. And you look at me and say, well, how do you know that's what it is? Or you're post-COVID. And you say, how do you know I don't have cancer? How do you know, maybe I have multiple sclerosis? How do you know? There is no test. It's me telling you that's what you have.
So you may see into a block of patients that you need to see them like once a quarter just to kind of see how they're...
Or more.
Just to kind of manage the process of...
And you need to treat them with respect. What we did with chronic fatigue syndrome, I to this day feel guilty about. And I saw some of those cases. Pardon me. But we need to acknowledge that they have a real problem.
Because we just wrote off some of us the crazy.
Yeah, you're just crazy, next.
Yeah.
And maybe Gulf War syndrome is a version of that. We had this Gulf War syndrome, and I was in the military at the time, and man, we examined and looked at thousands of soldiers.
But what shots didn't you guys get a whole bunch of... because you got a whole bunch...
Maybe that's the trigger, though, for your immune system.
Because you got, before you went in the country, everything. You had all kinds of stuff.
Oh, yeah, right? Malaria, yellow fever, polio.
Right.
I can't tell you how... I've got a shot record that looks like a phone book. No, so we have models for this, and historically, like you say, there are definitely events in the past, but we don't know. There, when you take all the things in your body, like you have a brain, you have a heart, and you have a pancreas, and there's a lot of that we have a pretty good handle on. But your immune system, I mean, that's like quantum mechanics, man. I mean, it's...
A question. This is something we talked about, I think it was a show or two ago. The vaccines is because of the messaging, the RNA, the Pfizer and the Moderna stuff. Do you think that in the booster shot thing, because they are a delivery mechanism, that we may be able to figure out some of that stuff, and maybe some of a booster shot or something like that can target some? They can design something to target some of this stuff, or no?
Oh, tough question. They can do so many things right now genetically. They can cut and splice and build and insert and extract. I mean, they can do so many things. But still, I mean, if you took the DNA in your body and you lined it up, it's like, it'll stretch all the way across the country.
Right.
Right. I mean, it's... But there's a couple interesting things that are happening. There is an antibiotic called minocycline. And minocycline is a form of tetracycline.
Okay.
And it's a medicine we've used for years and years for acne. That's about the only thing we ever use it for. But minocycline has this kind of unusual property of crossing into the brain and into the spinal fluid. And patients that have this chronic fatigue or maybe post-COVID seem to improve on minocycline. Well, let me back up. Most patients with chronic COVID, with long COVID, gradually get better, but very, very slowly. I mean, you're talking months and months and months, and still working at it. But the minocycline kind of is intriguing to me. We talked about that this morning. And then there is another medication called Naloxone. And you may remember Naloxone. It's also called Narcan, and that's the medication we use to reverse opioid overdoses. So if somebody took too much heroin or whatever opiate, and they're on the ground, and we give them a squirt of naloxone, they wake up. And so researchers now are using low-dose naloxone for some of these kinds of cases. Very interesting. So is it about the opioid receptors, or is it about...
It kind of resets some of the stuff.
Yeah, maybe. But there's nothing more frustrating than somebody coming in and you saying, I don't know what's wrong with you, and I don't know what to do about it. And neither does anybody else. I mean, that's a bad day for us. We don't like that.
It's tough to send a patient home with that, right?
Right. So, how'd your appointment go today? Well, there's nothing they can do about it. And I mean, it goes without saying that's going to be depressing.
Yeah.
I mean, all those patients, anybody with chronic disease has some element of depression. Sorting out the depression from the disease can be challenging, but this is going to be a real challenge for the medical folks. It's not going to be a challenge so much for the hospitals.
Right.
It's going to be a challenge for the primary
outpatient
care docs.
Stuff, huh? Yeah.
Yeah. I mean, I told people this morning, if you want to get rich, set up a post-COVID specialty clinic. And specialize. This is the center for post-COVID care. Now, there really isn't a whole lot you do other than support. But if you do that, man, there'll be lines going up and down the block in about a year or two.
Interesting.
Yeah, but those will be hard days too.
Well, because on a practical thing for you, as far as our local communities here, do you think that will be something that a lot of communities need to set up, like a support group or something like that, to where, hey, this is, so at least there's a place for these people to go?
Yes.
Okay.
Absolutely, yes. People, people with chronic problems do much better if they can talk about them.
Right.
And even if it's with family or, maybe close friends, but in a group where you can identify with others and you see that I'm not alone, this is a problem, and they have the same symptoms, it can be hugely beneficial.
Yeah.
And then on top of that, if you have that group, and let's say you threw in a little bit of professional therapy, and this is how you focus on chronic disease, these are some of the coping mechanisms we recommend, and maybe even a little bit of nutritional therapy.
Right.
These are the kind of diets that calm down your immune system and are likely to improve. I mean, it would be it would be a great thing.
Yeah. And one of the nice things about one of the things I love about our community is, they'll show up. They'll make this. That's one of the things that we'll do that. We'll get. We'll have something set up and where people have a place to go, and somebody will take it upon themselves to do it, or maybe the.
No, a couple of years back, I was kind of going through our local communities talking about the hospital and something called Measure A. And one of the things I would talk to people about is rural communities. How do they get help, and how do they survive in a system that is 80% urban?
Right.
And I said, look, nobody's going to come and help us. There is no Calvary.
Right.
We have to help ourselves.
Well, even the district now, they're doing like the classes for the balance classes and stuff like that.
Yeah, the state vertical classes.
Yeah, something like that is that, you already have some of the framework for something.
I mean, the people in this county are really great at rallying when they need to rally.
Yeah.
And I love that about rural living. I mean, like all these people kind of come out of their ranches and out of the woodwork and they say, okay, let's fix it, and they usually do.
Well, look at post-Butte fire. A lot of us realizes, a lot of things about rural communities that I love about them is we still realize that it's up to us a lot. The cavalry's not coming.
It's not coming.
It's
right.
It's not coming.
Right.
So even most people that come up here for tourists don't realize that a lot of our parks up here, there's not a Parks and Rec district that takes care of it. It's a volunteer organization.
Right.
It's like, really? Yeah. I mean, so, it's...
You don't have a Park and Rec district?
There's one in San Andreas now, but not like in Murphy's White Pines Park up in Arnold. I mean, those are all... Some people decided they were going to take care of the park. Yeah. So, all right. Okay. Other stuff on COVID you've seen. The other questions from the supervisor, and this is one, is the vaccine, the volume of vaccines. When are we going to start seeing them in volume, and maybe pushing them out to the pharmacies, and that? When are we going to start seeing them?
Are you trying to frustrate me?
So you're not getting anything more than anything.
This is frustrating.
Okay.
This is really, really frustrating. The vaccine delivery distribution is managed by the state of California, and there are many of us out there that are ready, willing, and able. But it's right now it's a very fractured system. In some of the healthcare groups like Sutter, I think Dignity, Adventist, Kaiser are getting their deliveries. Some of the pharmacies are getting their deliveries, but it's kind of all over the map, And you go back to Sacramento and say, what can I expect? And
do you think we would be better in some of the states, like it was West Virginia, and even some of the stuff on Florida, where they basically haven't tried to manage it so much as, okay, we have this vaccine in, we're going to have the drive-through thing here, give them your license, and if you're over 65, so to speak, get in line. Instead of trying to manage it, just basically as the stuff comes in, just get it out the door as fast as possible.
And if somebody's in line, vaccinate them.
Yeah.
I don't care if they're 75 or 65 or 30. If they're in line, vaccinate them. I mean, that works. And you can't
Because you don't try to man it. You just,
you just start vaccinating.
Yeah.
And then, I'm a little bit reluctant to say this publicly, but then there's all this paperwork tied to it.
Bingo.
You have to fill out the forms. You have to register with the state. You have to enter their vaccine history. You have to, do a handstand. And you just go, look, we just need to
drive
vaccinate
through, get them
people.
there, put a sticker on their license, and they move on.
Yeah,
Done.
let's just do it. I have, when my clinic started talking about being a vaccination hub, I had 7 registered nurses call me. 7 different nurses call me and say, we're retired, we're still licensed, we're still healthy, you want some help? Like you're saying, like rural communities help themselves. Mm-hmm. Man, I had all these volunteers. They're still calling. And they're saying, the Rotary, they're calling and saying, we want to help, just tell us where to go. Mm-hmm. You say, well, there's this problem, the state has the vaccines, and, it's kind of like a gun without a bullet.
Well, we know that the production levels are ramping up significantly.
So that's
in theory. I mean, at some point, this is going to be a self-liquidating. I mean, because one would guess that in 90 days we're going to have more vaccine than we know what to do with, right? Isn't that in theory?
It is controlled by government, and there's things government does well. Kind of a shorter list, and there's things government doesn't do very well, and this is something they just don't do well. And it'll be interesting to me. I believe California now just contracted with Blue Shield and Kaiser to manage their distribution system. And that's kind of part of the problem. Not that they contracted with them. The problem is every day there's a different plan. In December, it's all going to be public health. And in January, it's going to be the pharmacies. And in the middle of January, it's going to be the pharmacies plus the dentists. And you just go, could you just decide and do it? And now it's going to be Kaiser and Blue Shield. Maybe that's a good idea, maybe not. But every time you change the plan, everybody backs up and says, what do we do now?
Rather than just like, okay, we got 100,000 doses, roll up your sleeves.
Yeah, let's go, man.
There's going to be a drive-through at every...
How hard is it?
Every,
right?
Right. Yeah.
Right. People are really frustrated.
Yeah.
But
we're down to about our last minute here, so I guess a summation on this as far as what you're...
With the vaccinations?
Yeah. I mean, as far as what... is
People need to continue to do the protective measures. They need to wear masks. They need to be careful. They need to be super careful with large groups indoors. They need to be patient. It's coming, but they need to be patient. And complaining about it is not going to speed it up. It's just not. And it's as frustrating for the medical people as it is for the patients.
Right. Thank you for sharing your stories today. I mean, this was, a little, drop the veil a little more than normal on this. And
that's great.
But thank you.
Yeah,
Thanks
thank
for
you,
what
John.
you do.
I enjoyed it.
Thanks.